All right, so thank you all very much for coming today. Thank you for being here. It's a great gathering. It's my first time here, and it's just so wonderful to be here. So I have the distinct honor and pleasure today of introducing one of the best in the business, Dr. Stephanie Randle. Dr. Randle is an associate professor of child neurology and epilepsy at Seattle Children's Hospital and the University of Washington. She's co-founder and director of the TSC program, which recently was named an Epilepsy or TSC Center of Excellence. So congratulations on that. She completed her undergrad training at UC San Diego with a major in neuroscience. After working at a functional MRI lab, she went on to receive her master's in physiology and attend the medical school in Chicago at the Chicago Medical School. She completed her pediatric residency in the University of Chicago and then moved to Seattle to complete her pediatric neurology and epilepsy training through the University of Washington and Seattle Children's Hospital. It's my honor and pleasure to introduce Dr. Stephanie Randle.
Thanks, Paul, and thank you everyone for joining us today. As you know, the talk today is going to be on ESES, but you can see the title is a little bit different as the name has recently changed, but we'll go through all the definitions. And please feel free to interrupt, ask questions. This talk shouldn't last, an hour, so we'll have time at the end also if you guys like. So I have nothing to disclose, with the only caveat that we're going to be talking about some off-label treatments for the treatment of what was formerly called ESES. Here are my objectives today. Because this is a condition that is typically brought out by sleep, we're going to talk just a little bit about sleep. We're going to talk about some of the medical terms that we use in epilepsy in general, as well as in sleep. And then we're going to dive more deeply into the disorder that we're all here to learn about today, ESES, with the new name of EE-SWAS. So it's a mouthful. We'll talk about treatment, and then we'll talk about future directions. So first off, let's review a little bit of the sleep physiology. So as most of you know, sleep is broken down into 4 stages. We spend the most of our night sleeping in the N2 stage, or that lighter green one. Let's see if so the lighter green section. Oh, here we go. Okay. But then throughout the night, the amount of time we spend in each stage of sleep kind of changes, which I'll show you in the next couple of slides. So most of us go through 5 stages of sleep, and you can see at the beginning of sleep, we're spending more time in those like stage 1 through stage 4 portions, and as the night goes on, we tend to spend more time in the REM portion of sleep. I really like this graph. I think this is the easiest one to kind of interpret. And so we'll start at the far kind of right side of on my side, where 10 p.m. we think about when people go to sleep, and you really start off in that lightest stage of sleep, N1 sleep, very briefly. And then we start to go into that more teal color N2 sleep. And you can see as the night goes on, that portion of sleep really continues. But then as the night goes on, you can see the darker blue becomes more common, that's REM sleep, and the deeper sleep, or the lighter blue, becomes less common. And I promise there's a reason why we're kind of talking about all this. So the way that the physiologists kind of describe sleep is based off of an EEG. And so as you know, many of you have probably experienced an EEG either yourself or for a loved one. And when the electrodes are recording, we look at when someone's awake. And this is a really normal looking EEG. And so the way I look at studies, we have the right side on the top, the left side on the bottom, and then there's a cluster of 4 squiggly line groups, and those are kind of broken down based off of where they are in the brain. And so the F letter is in the front and the O letter is in the back. And in a normal EEG, in the O letter, the squiggly lines are really nice and rhythmic and well organized. When someone starts to get drowsy, you can see that those really nice squiggly lines in the back kind of go away. And the EEG overall is just less exciting, it's kind of slow. And that's really quite normal for a drowsy EEG. As we get into N2 sleep, say this is kind of the most exciting sleep stage for most people, you start to see these vertex waves in the middle of the brain, and then the really rhythmic stuff you can see is what we call sleep spindles. And so the reason why this is interesting for this talk in particular is that we think a lot of the reasons why people develop that ESES problem or pattern is probably driven by the same parts of our brain that are making these nice sleep spindles. N3 sleep, I told you, is the deeper stage of sleep. This is probably the stage that most of us spend the least amount of time in, although it's thought to be a really restorative portion of sleep. And overall, the EEG gets very slow. Not a lot of exciting features to look at in this stage. And then finally, the fourth stage is called REM. A lot of us have heard of that, rapid eye movement sleep. This is the stage where most people are dreaming. This is where there's a lot of consolidation of memory. And actually, it looks a lot like when someone's awake. You just don't have that really nice looking background activity. So why do we fall asleep, and how does this happen? And I'm not a sleep neurologist, so I'll just give that caveat. But you can see on the lower corner, there's a table that talks about the different chemicals in the brain that help trick your body into thinking it's time to go to bed and it's time to be awake. And so we're always kind of struggling, to stay awake. We really need those like glutamate, serotonin. We need those chemicals to just really be active in the brain. And then as we start to get drowsy or fall asleep, the adenosine, the GABA neurotransmitters, melatonin, those are really starting to amp up. And in fact, caffeine works on adenosine and blocking adenosine. That's how it's thought to keep you awake. But in the upper corner, you can see the nice picture of the brain. And what that's highlighting is the relationship between the brainstem, the middle of the brain called the thalamus, and the hypothalamus, and then the cortex, which is on the top part of the brain. And so the combination of those three main areas is what helps tell the body it's time to go to sleep. You can see over here the suprachiasmatic nucleus. That's an area that is connected to our visual fields, actually. And so we get a lot of response from light. And so if we're getting a lot of light shown into our eyes, then our body's not going to think it's time to go to sleep. But then if you turn the lights down, you get into a quiet room, the brain starts to produce more melatonin, thinking it's time to go to sleep. Oh, and sorry, one last thing, the thalamus. It's a really amazing part of our brain. We have two, one on each side. They have multiple nuclei in them. They all kind of do different things. But we really do think that the thalamus has a really integral role in epilepsy in general, also in ESES, which we'll talk about a little bit more. So a few kind of common terms for seizures, which most of you probably know. So a seizure is just a sudden change in electrical and chemical activity in the brain that's causing too much excitation. And so we usually say that everyone's allowed one unprovoked seizure, but then the caveat is if you have an EEG that really shows you're at a high risk to have more seizures, then we might say you have epilepsy. So if you've had more than one seizure or one seizure with a high risk of recurrence, that's definition is epilepsy. Ictal is a term we use for during the seizure, post-ictal is a term for after. Many people are confused, sleepy, and then anti-seizure medication is the term we use for the treatment of epilepsy. We talked about EEG, that's just a brainwave test to tell us what someone's risk is of having a seizure, or are they having a seizure right now? Or more importantly, with this diagnosis of ESES, are they having a really significant change when they're sleeping that puts them at a risk for cognitive changes? Discharges or spikes are just the risk of the seizure, and it's helpful to know where they're coming from. The spikes can tell us what part of the brain is irritated. Sometimes the EEG will tell us you're having a seizure right now, and we didn't know. And sometimes it'll say, the brain isn't working as strongly in one area as another. We call that slowing, and I have a couple of examples that we can show you. As many of you know, with an EEG, we often do some provocative testing like flashing lights or having someone blow on a pinwheel. And really the point of that is to see if that can bring out a risk for seizure, or a seizure for that matter. We talk about focal seizures. Focal seizures come from one area of the brain. It's obviously a very simplified term. Some common signs you can see listed down below. But in reality, what we're hearing when someone's describing their child or their loved one's seizure is that one side of their body is usually affected more than the other side. In a generalized seizure, we used to say that seizure comes from the whole brain at once, when in reality it's probably coming from deeper areas of the brain like the thalamus, but then being expressed everywhere. And usually when someone has that seizure, they have whole body involvement, so not just the right side or the left side. sometimes you have a focal seizure that then turns into a generalized seizure, and it can be very confusing to know where the seizure began if you didn't see the very beginning part of it. And so that's why your neurologist may ask you a lot of questions about how did the seizure start, what did it look like, etc. Okay, so a couple more nice EEG pictures. So we showed you this one already. This is a really normal, healthy-looking waking EEG background. It's really well organized. We're not seeing a lot of slow activity or none of the risk of seizure that we're worried about. But in this example, you can see on the top part, there's a patient that's having a lot of spikes or the high risk of having a seizure. On the top part of this one, you can see that there's an actual seizure on that part of the brain. That's coming from the right side of the brain. It starts off with a little bit of faster squiggles that then kind of turn into slower squiggles, but really they're just very rhythmic, and that's something we look for when we look for a seizure on an EEG. And then the slowing I mentioned, you can see where the arrows are pointing in that area. The brain waves are just not as strong as other areas, and that could be because there's an injury there. It could just be that the cells aren't working as normally as they should.
When you say slowing, do you mean like, I don't know.
Yeah.
What does that mean exactly?
So here you see, so sometimes you'll see on an EEG report that there's one area of the brain that's a little slower, and all that means is that the frequency of how fast the squiggles are happening are just not as fast as it should be.
More like a wave.
Yeah, exactly.
Yeah,
you see, so here's a little bit more of a slow wave, whereas here is you're not seeing that slowing. Yeah, great question, thank you. I will say that slowing I think is one of the hardest things to learn as an EEG reader. I'm not expecting you all to have to interpret EEGs after this talk, but something that I think really alarms people when they see that on their EEG report. Okay. So I mentioned that you can also have generalized seizures or generalized discharges on an EEG, and that you can see the spiky stuff in the very middle is kind of taken over everywhere. It's not just in one spot. And then sometimes you have a generalized seizure, and that's just usually a longer period of those spikes on an EEG. Often, sometimes the patient will stare or have some lip smacking. Sometimes that'll turn into whole body shaking. Okay, so why all that build up if we're here to talk about ESES, or really the new term, developmental epileptic encephalopathy with spike wave activation in sleep? And I'll tell you kind of why the acronyms are there like the way they are, or we'll use the term EESWAS. So in 2022, just last year, the ILAE, or International League Against Epilepsy, they're the governing body that helps us define seizures. And they're always keeping us on our toes and kind of refining how to best describe someone's seizures or epilepsy. And so prior to 2022, we used these three terms on the left in blue. So ESES, CSWS, and LKS. And I'll have that on the next slide. We'll kind of go through that. In 2022, they said, you know what? All these letters aren't making a whole lot of sense. We don't have a really great consensus of how we diagnose this disorder. And so let's try and become a little bit more clear in our diagnosis. So ESES was termed electrical status epilepticus of sleep. And what that referred to was how frequently someone's having discharges on their EEG when they're asleep. And so normally we would say, okay, we want the discharges to be more than 85% of that non-REM sleep period. So either drowsiness, N2 or N3 sleep, like I showed you. And so we would take the EEG and we would, as an epileptologist, we'd go through it and we would mark every time there was a discharge and then take that percentage over the night's sleep. And so to get the diagnosis, you had to have it a certain percentage of time. I'll tell you that most epileptologists wouldn't even agree on that 85% number. Most of us wouldn't even agree on how to calculate that number. And so that was part of the impetus for the ILAE to want to change the name and the definition. We also would use the term CSWS, or continuous spike wave in slow wave sleep, here on the bottom. And that really referred to the clinical issues related to the ESES. So now we're saying, okay, there's an EEG problem and then there's a behavioral or clinical problem, whether that's regression of language, regression of motor, changes in behavior, some more like ADHD or more temper tantrums, things like that. So now in 2020, since 2022, and I'll tell you, like, all of us still use these other terms, but really to be accurate, since 2022, we've really started to move forward with this term EESWAS. And the way we get that definition, or the way you can get that diagnosis, is you have to have some sort of regression. Typically it's global, so it can be in any one of these areas as listed below. So whether it's regression in learning in school, so cognitive regression, a regression in language, so at first you could understand everything said to you, and now that's really hard for the child to do. Sometimes they can have a change in their speech production. It may be that you have new movement disorders, or even maybe a regression in your motor skills, like you were walking and now you're not as interested in walking. And then the behavioral piece is a huge part of it. So many kids with this condition have ADHD symptoms, worsening behavior like temper tantrums, trouble paying attention, etc. The other way to get, you have to have this other piece of it to get the diagnosis based off the EEG. And so before I told you we had to have at least 85% of the EEG to have spikes on it. Now really all we're saying is it has to be markedly different from wakefulness to sleep. And so what does that mean? We're still kind of coming to that definition together as a group, but that's how we're defining it now. And I think the really important piece of it is sometimes kids will have really abnormal EEGs when they're awake and really abnormal EEGs when they're asleep. And that may not really meet this criteria because we really want it to be different within that sleep stage. Here's just another nice picture of a child with ESES. The wakefulness EEG on the right side, the sleep EEG with activation of the discharges on the other side of the screen. And really you're just seeing that those little spikes are near continuous when the child's asleep.
There's a question about the best way to quantify the percentage.
Mm-hmm.
And they say within the first 5 minutes of sleep. Is that still?
That's a really great point. We used to, and still, I'll say I still do this when I look at ESES EEGs. We usually will take, ideally you would take 3 periods of sleep overnight. So something in the first portion of sleep, something in the middle, and then something in the end. And then take 5 minutes of that, and then you'd average the 3.
5 minutes of each of the stages?
Yeah. 5 minutes of each of the blocks. So here I can go back actually.
So not of the whole sleep?
Not of the whole sleep. So you would take 5 minutes from like this portion, 5 minutes from this portion, and then 5 minutes ideally from that portion. And then average that together.
Gotcha, thank you.
Yeah. Thank you for your questions. But you can imagine, I mean, there was a science to doing that. There's also just the epileptologist going through and measuring it.
Would it would be 5 continuous, or would it just like, okay, we'll take a little bit here in non-REM, we'll take some in REM in each of the cycles? Or
No, so 5 continuous in non-REM sleep.
non-REM sleep?
Yeah.
Okay.
Because we know that the non-REM sleep is when this is most abundant. We also know that in most people, these discharges are more common in N2 sleep, which is more frequent at the beginning of the sleep cycle. And so that's where, you might take just the beginning of the sleep and it's really active, but then the very end of the sleep cycle, when you're closer to waking up in the morning, it's not active at all. And so then the average sometimes would then be less than 85%, for example. I would say now that it's a little bit less important because really the definition now really is there a cognitive behavioral change and is the EEG just significantly worse when they're sleeping? We kind of got rid of that 85% rule. I'll say this is a hard talk to give because there's a lot of, there aren't great criteria for defining things. We all used the 85% number for a long time, and then a lot of us started using more like 50%, because we knew that, well, 50% of sleep is still a lot, and we were still seeing cognitive changes in children who had that activation. So in some sense, the change in the name and the definition has made it a little bit easier for us to diagnose this in somebody.
So then how do you, now if you don't use those percentages anymore, how do you
I will say that most of us still follow the percentages, but then you could argue, well, if your child was at 85% or 90% before and now they're at 70%, the argument is still, well, how are they doing clinically?
So if you already have a child who's already developing easily, how do you move those cognitive changes?
We can talk about that as well. Yeah, I think that's a little bit harder. That's maybe where the EEG makes it a little bit easier for us. But I'll get to that in a minute. Yeah. So kind of just to emphasize that it can be easy for us to say, man, the EEG looks a lot worse when you're sleeping. Let's diagnose this child with ESES. But in reality, we need to have that clinical piece of it where there's a change in their functioning. I see lots of kids where their EEG is much worse when they're asleep, but their parents say, no, they're doing fine. Cognitively, there's no change. We do neuropsych testing, there's no change. And so we keep watching. So maybe I'll get to your question a little bit more on this side. So ESES is actually quite rare. In the very middle, you see that about 0.5% of children with epilepsy will develop this. And so it's most commonly, the onset is most commonly around the ages of 4 to 5, although it can be between 2 and 12. Males and females are typically affected at a similar rate. Most people, about 2/3, will have normal or typical development before the onset of the SWAS, but about 1/3 will have cognitive impairment or some challenges in their development preceding it. And that's really where we get that extra letter in the acronym. So DEESWAS just refers to someone who had challenges with their development prior to the onset of these EEG changes. But you really have to have a regression. And I think maybe that's where it's hard if someone's nonverbal, wheelchair bound, you're working probably closely with your physical therapist, your occupational therapist at school. That's where it'd be really helpful if they said, well, John is now no longer doing this task that he had done before, and with your neurologist you get an EEG and it shows this activation in sleep. But it can be quite a bit harder. Children with this condition often have epilepsy or seizures. A minority will not have seizures though, and most people, if they have epilepsy, they'll have seizures preceding this EEG abnormality. The seizures can depend on, the type of seizure they have can depend on the cause of their seizures, but the majority of kids who end up going on to have EESWAS will have focal seizures initially. You can see at the very bottom, well, maybe not all of you, but I have an X through tonic and an X through spasms. And really, you're not supposed to have that type of seizure semiology to have this condition. And then you can see over on the other side of the screen that, like I said, the seizures typically precede the EEG abnormality and the regression, and the cognitive changes are typically slow, and so sometimes it can be hard to pick it up right away. I will say that, I am an epileptologist. I take care of kids with epilepsy as my primary practice, and in these cases, the epilepsy is usually not the problem. It's usually the cognitive piece of it. Most of these kids tend to have seizures that kind of got better, but the EEG gets really bad, and the cognitive piece of it is the problem. So why does this happen? I think this is like the million-dollar question. And we think that it's really related to the thalamus, like I showed you before, and then the cortex, or the top of the brain, and that connection. And those connections are what drive those sleep structures that we had just spent so much time talking about. And so we know that in almost everybody with epilepsy, their EEGs can worsen when they fall asleep. A lot of people have seizures going into sleep, waking up from sleep, during sleep, and that's probably related to these corticothalamic oscillations or connections. And so we think that that's why this happens in some people, but to be honest with you, the real reason is still unknown for the most part. There was a study that looked at kids with this, what they called ESES at the time, and they looked at where on a functional MRI things were most active in wakefulness and in sleep, and they saw, you can see on the top part, the red dots in the very middle, that's the thalamus. And then in the patients who had areas, kind of what they call the temporal lobe, on the bottom picture, the frontotemporal lobe, is where things were most active in this condition. I'd say we still don't know with full certainty why this happens to some people and not others. In a nice review, they looked at hundreds of children with this condition, and you can see broken down on the pie chart on my right, the majority of kids had a structural cause for their epilepsy or their EES-WAS and epilepsy. About 10% had a genetic cause, 1% had a metabolic cause, and then the rest were kind of in this unknown category. So either the genetic testing didn't reveal anything or the MRI didn't reveal anything. Then you can see on the my left-hand side of the screen, the top picture is a patient of mine who had a malformation of cortical development or a structural change related to her tuberous sclerosis complex. You can see the patient in the middle is one of our kids who had a stroke very early in life. A really common area is called the MCA area, or middle cerebral artery area. And there's that little, the black area in the middle is where the fluid has filled in after that part of the brain was injured. That area led to the patient's epilepsy and probably their EES-WAS. And then finally, the most bottom picture, you can see the arrows kind of pointing to the brighter stuff in the very middle of the brain. And so that's the thalamus, the area we've been talking about. And this is a child who had a stroke in infancy, or we call HIE, hypoxic ischemic encephalopathy, very common cause of epilepsy in children. But kids who tend to have these strokes in the thalamus more often will go on to have this condition, EES-WAS. In this review, they looked closely, sorry, I know it's like super small, but they looked at the different genetic causes of this condition. And really, the most common genetic cause is a mutation in the GRIN2A receptor. This is a receptor in the brain, or a gene that codes for a receptor in the brain that is responsible for excitability in the brain. And so the patients who have this condition have a harder time decreasing that excitability, putting them at a higher risk of seizures, and particularly this condition. But you can see a whole list of other genetic causes. A lot of these genetic conditions lead to structural changes in the brain. So you could argue, is it the genetic part of it, or is it the structural brain part of it that's causing the seizures? I wanted to spend a minute talking about LKS, or Landau-Kleffner syndrome. As you remember, that was one of the three terms we would use for this condition. Now it's still a subtype of EES-WAS. It's a very specific change in development with the EEG abnormality when these kids usually had typical development preceding their condition, and then they had this acquisition of trouble understanding language. And that's really quite rare in our patient population. Most kids, they may not be able to speak a lot, but they can understand a lot of what's said to them. I hear that all the time from parents. My child, he doesn't speak much. He maybe points to say what he needs, but he understands everything I say to him. And so this is kind of the opposite of that. These kids can say things, but they really aren't understanding what's being said to them. And so it's a pretty devastating type of epilepsy, as you can imagine, if they're developing typically and now all of a sudden they're not understanding language. Why is that happening? These kids will have seizures, but it's actually not a huge feature of their condition. May have the behavioral changes I have listed below, also not a huge feature of this condition, and it's usually a pretty young pediatric onset condition. Interestingly, we know that in this condition, kids tend to have more irritability over that temporal lobe, particularly in the back of the temporal lobe, which is the area that we know is responsible for understanding language. So it's really nice when things make sense in neurology, and I think this condition overall tends to make good sense to us, why kids have that regression of auditory understanding language. But it's the same with the rest of ESES that we've been talking about. The EEG is pretty unremarkable when they're awake, but then really activates when they're asleep. So here's just a little bit of a summary, and I apologize, I know this one's also kind of small, but bear with me, we'll kind of go through it quickly. You can see, we'll start here. So my right, and work our way to my left. So the first column is what we call selects. It used to be called benign Rolandic epilepsy, or BRE, which I think everyone still says because it's much easier. And these are kids who usually had normal development, very minor, minimal cognitive changes related to their epilepsy, maybe had only a handful of seizures in their lifetime. Usually the seizures can be twitching of the face that may not generalize. And often we don't treat with medicine, we just watch these kids. Their EEG abnormalities are usually over like the middle of the brain to the temporal portion of the brain, so kind of above the ear. But when they'd say this is all on a spectrum, right? So that's kind of the more benign end of that spectrum. The second column you can see is SELAS, or CELAS, used to be called benign occipital epilepsy or Paniatopoulos syndrome. Those kids are very similar to the first column, just their seizures tend to come from the back of the brain or the occipital lobe. Also usually with very rare epilepsy, and those seizures tend to be like, they often look like a migraine really, where they can have really bad headaches, very nauseous, lots of vomiting, and then often will go on to have shaking, which is how people know that they have a seizure and not just a migraine. LKS is the third column. We just talked about Landau-Kleffner syndrome in those patients that have the regression of understanding language. And then all the way on my left is the condition we've been spending the most time talking about, or DEESWAS. I just wanted to have a slide on Lennox-Gastaut syndrome because interestingly, we used to think this was part of the spectrum, although I would argue that it's really a separate condition. And I think the new definition of EESWAS has helped separate the two even more. So children with LGS tend to have their epilepsy prior to 18 years of age, so in pediatrics. They have very specific features on their EEG. So in the middle, the yellow one is what we say is like very fast EEG features in the middle. Everywhere, or generalized. They have the epileptiform discharges you can see over here on my right, but those are present like throughout the whole study, when they're awake and when they're asleep. And their predominant type of seizure is called tonic seizures, the stiffening seizures, and that we said is something we don't tend to see in EESWAS. And the reason why we really want to separate these out is because we tend to treat these conditions a little bit differently.
Are you saying that that's like a past part of the spectrum of this? It's not?
I would say that it's really easy for me to say, okay, something's clearly the ESES and something's very clearly LGS, or Lennox-Gastaut syndrome, but there were a lot of kids that fell in that middle portion, and I would say it was somewhat of a spectrum. But now we're trying to say, okay, you have clearly LGS, and you clearly have EESWAS. There's still going to be people that overlap in both groups.
Then people would have both, right?
You probably wouldn't have both because with LGS you tend to have a really abnormal EEG when you're awake as well as when you're asleep. And you kind of have to have tonic seizures at some point in your disease course with LGS, whereas they've kind of taken that out from the EESWAS group.
And you have the ESWAS or the CSWS and then improve and get down to LKS. Like, can you go down? Like, is that possible?
I have a picture kind of towards the end that might help answer that question. I think that'll answer your question. So let's talk about treatment and prognosis. So I like to think of treating this condition kind of in two areas. As I mentioned, most of the people with this condition don't have really active epilepsy or seizures as their problem. Really, they're electrographic. They have an electrographic problem or an EEG problem. And so, you've probably heard your doctor say, we don't treat tests, we treat patients. But I'd argue in this condition, we're treating a test. We want the EEG to look better. And so how do we do that? We either use an anti-seizure medication or other medications. We can think about surgery, we can think about dietary therapy, and we'll get into more detail for those. And then on the blue side, we talk about, well, how do we improve the cognitive and behavioral issues related to this condition? And so working really well with a speech therapist, physical therapist, occupational therapist, a neuropsychologist, a neurodevelopmental pediatrician, an expert in ADHD, are all ways to really optimize the cognitive and behavioral side of it. As well as there may be medications required if you have more of that inattention or hyperactivity component of ADHD, or maybe some of the behavioral challenges that can come along with this condition. So anti-seizure medications, you can see I have the 6 kind of most common listed, really with valproic acid, ethosuximide, levetiracetam, and clobazam being kind of the most commonly used. In the bottom I have high-dose benzodiazepines or diazepam, which clobazam is a type of benzodiazepine. It's just really great that we have a couple of different ways of trying to use benzodiazepines to treat this condition. As many of you know, all of our medications come with risks, and so sometimes it's a discussion between the provider and the family about what risks they're willing to take, what other medical problems the child might have. Do they tolerate blood work? Do they have an allergy to a certain medication? And that's what might help us guide the first or even second line treatment. Whenever I explain anti-seizure medications, I like to kind of break it down into 5 different areas. And so we mentioned the problem with seizures is that the brain is too excited. And so how do we quiet down that excitement? And so it's really either you increase inhibition or you decrease excitation. And so that's kind of where and you can do that in different parts of the brain. And so this is just cell 1 is the first cell, and then cell 2 is the second one, just representing that the cells are just talking to each other too much. So we'll take it one step further. Cell 1's on the top, cell 2's on the bottom now. And you can see I've circled some of our favorite medicines in this condition. Really the high-dose benzodiazepines or clobazam, you can see here. And that tends to work really well by bringing in extra inhibition into the second cell. So the first cell can be really active, but the second cell is just saying, don't worry about it, let's quiet things down. You can see levetiracetam or Keppra, probably most of you have experienced that medication before. That medicine helps decrease the amount of excitation that's coming out of the first cell. I put an X through the top part because you can see that those medicines tend to be more of what we call focal seizure drugs, and most of us tend to stay away from that class of medicine in this condition. So I love, trileptal carbazepine. We use that all the time in epilepsy, but for this condition, we may want to stay away from it because we know that the ESES is coming from kind of deeper parts of the brain, and even though there might be a stroke in one area, the whole brain is a bit more irritated in this condition. Moving away from traditional anti-seizure medications, we also use immune therapy. Many of you have probably had experience using steroids in this condition. Steroids can work really, really well, but as you may know, it's not something that's a good long-term solution. The longer you stay on steroids, the more risk of side effects you can have, the harder it is for your body to produce the normal steroids that we should make, and so you have to be really careful when you start and stop this kind of medication. You can either use a pill form, a liquid form, sometimes we'll use an IV form of steroids, kind of depends on the situation. I would say most of my patients, if they've failed one of the traditional anti-seizure medications or benzodiazepine, we're pretty quick to jump to trying steroids because we know it can work pretty well. IVIG is another immune modulated therapy. It's given through the IV as the name implies. The IG part stands for immunoglobulin, and it's just pooled immune therapy that from blood that's been donated. And some of the risks with that is it's very expensive, and the insurance often won't want to pay for it. It's hard to know if it'll work for this condition specifically. It's usually an infusion over the course of a few days that probably needs to be repeated monthly or every other month for an extended period of time. And so I'd say that most of us are willing to try that, but it may not be as easy to get or to use as some of the other treatments. There's been a lot of excitement with amantadine. Amantadine is a medicine that helps increase dopamine in the brain. It's being used with dementias and other neurologic diseases where cognition's an issue. I would say most of us think overall amantadine is quite safe, but how effective it is for this condition is hard to know. There aren't a lot of good clinical trials based off of that.
Real quick, when you said there were different causes, you said it was like genetic, versus blah blah blah, but there was nothing. Wasn't anything saying like immune, but yet there's immune therapy. So can you explain that part? Like, why are we treating it? He's on all those 3 things that you pretty much listed, but why on earth
Great question.
Why was the immune not part of the treatment or part of the cause of it?
Yeah, no, that's a really excellent question. We think that the immune effects of like prednisone, for example, can increase the amount of GABA, or that inhibition neurotransmitter in the brain. We use steroids for other types of refractory epilepsy as well, so not just this condition. But yeah, it's definitely confusing because we're saying that it's not like an allergy to your brain that's causing this, like in some of the encephalitis conditions we take care of. In this condition, we're just saying that the brain is overly active at night, and that's, I think, the other hard part is there haven't been any good studies looking at other immune modulation, like some of the drugs we might use in refractory epilepsy, for example. I will say also that we're not checking spinal taps on everybody who comes in with this condition to look for immune deficiencies or overactive immune systems.
So is there an inflammatory process then that you're thinking of why you're heading towards the immune therapy for some people, some sort of involving cytokines or not? Or?
I think that's a great question. We know that we don't think there's a direct immune response in the brain that's causing the ESES or EESWAS. We know that the steroids can work in a few different ways, in part reducing inflammation, but also by increasing inhibition, and that's probably why it's helpful in this epilepsy syndrome in particular. In other epilepsy syndromes, it can be that there's too much inflammation, and that's why the steroids are helpful. I haven't had as much response to IVIG or improvement with IVIG like we do see with other more immune-mediated epilepsies, and so that might be why it doesn't work as well, because there's really not a huge inflammation component to this disease that we know of.
When you say not work as well, are you saying like they're dependent on it, meaning like they keep needing to go back to go get it, or are you saying like the needle doesn't move now, like the change?
The response isn't as good as with the other therapies. So yes, you would need IVIG given repeatedly over time, but because we know the effect of IVIG only lasts, usually they say 2 to 4 weeks, which is why we usually give it about every 3 to 4 weeks. Prednisone you take every day, and so our medicines don't work long term. It would be nice if you just gave it once and then it worked and you didn't have to repeat it. But no, I don't think IVIG, people typically don't have as good of a response to IVIG in this condition as they do with other treatments.
And if they do respond to it really pretty well, like the needle moves,
Yeah.
then what does that mean? Then for that case, is that an immune?
So for that case, I think then most of us would just keep using it, following the EEG closely. It's looking for improvement on the EEG. And then at a certain point, as EEG starts improving, can we space out how frequently we give IVIG? Can we stop giving IVIG? Has the child grown out of this condition? Because we'll see that most people will stop having this abnormality on their EEG at night. And so really, it takes time to get there, and we want to make that time, we want to help with the child's cognition and development the most during that time.
And amantadine, that's not an immune-based
No,
medication.
it's not.
Something totally different.
Right, yeah. So that tends to work more with dopamine. And we know that there's a connection between the thalamus and the cortex of the brain related to dopamine. And so, we don't know exactly why it would work in this condition, but it's been tried. I'd say most of us, before saying, we have nothing else to do, would try amantadine. It's usually a relatively low-risk treatment.
And that's usually for the cognition part, right? Of the brain that's been terrorized by this.
Because we're not really seeing that the amantadine doesn't tend to improve the EEG as much as some of these other therapies can. Yeah, wonderful questions, thank you. So surgery, I'd say, is actually a bit of a controversial topic in this condition. The cartoon drawing on my left represents the multiple subpial transection that was really discussed years ago, maybe offered years ago. I would say that our surgeons can do this procedure. I haven't seen them do this procedure in many years. And for ESWAS, it's unclear how beneficial it can be. But in this procedure, what the surgeon will do is they'll remove the skull. They'll make some cuts to the long part of the cell I showed you in the picture. They call that the axon. And they kind of disconnect the cell body from the other areas. In theory, it shouldn't cause a whole lot of cognitive changes or worsening by doing this procedure. If your area of abnormality is really close to an eloquent area like motor or language, this is thought to be a good option because you're not taking out the area that's really critical for this child's functioning. So I have it in here because it's something that you might hear about or you might read about, but something I'd say most people don't do much anymore. On the lower right-hand side of my right-hand side of the screen, you can see the MRI, and there's a little white hole, and that represents a child who had part of their brain removed because they had a tumor in that area that was thought to be causing their ESWAS, and so surgical resection can be an option. There have been a few case series looking at different types of surgeries for this condition. The top one talks about hemispherectomy. The bottom one, they say focal, or they talk about surgery where majority of the kids in this bottom paper also had a hemispherectomy. And that's a really big surgical procedure where they either remove or disconnect half of the brain. And in these kids, they tended, all the kids in the top and in the bottom who had the hemispherectomy had an improvement or resolution of their seizures. But I think the caveat to these studies is these are kids who are having refractory epilepsy. So they have seizures all the time, and they have the ESWAS. Whereas I'd say for the average person with this condition, they're not having seizures all day, every day. And so we don't often jump to doing a big surgical procedure if you're not having also refractory epilepsy. The paper over on my left-hand side really looked at the focal resections, as I mentioned, taking out one small area and seeing if that could improve developmental and EEG outcomes. But also those patients had continued epilepsy or seizures. And so I think that you would argue that this is a little bit of a different patient population than just the average child who has ESWAS without refractory epilepsy. There's been a lot of excitement about the dietary therapies for this condition. Most of us talk about this as called the ketogenic diet, although there are 3 forms of the diet: modified Atkins, low glycemic index treatment, and ketogenic diet. And really what this does is it tricks your brain into using a different fuel source for energy. So instead of sugar or glucose, it tricks your brain into using ketone bodies. There hasn't been a whole lot of research into using the ketogenic diet for ESWAS. There's a whole lot for refractory epilepsy, which is a separate topic. But in this condition, there have been a couple of review papers, the best probably by Dr. Kossoff's group out of Baltimore. And they really looked at how did people do over time, summarizing multiple studies you can see on the left. And really the most important columns, I'd say, are the last 3 on my left, looking at EEG improvement and cognitive improvement. And I'll summarize it for you because you probably can't read it very well, but it was a huge range. So somewhere between 30% and 100% of people had EEG improvement, and somewhere between 17% and 100% of people had neurocognitive improvement. And so something that could be considered and discussed with your neurologist if interested, but hard to know how well it'll work for this condition. So to try and kind of summarize the treatments, I have you can see the anti-epileptic drugs, steroids, benzos, surgery, and others. And really, steroids tend to provide the most improvement either from the EEG or cognitively. Surgery can be a really great intervention for these patients, but I think that's a very specific subgroup of people that we're talking about. And usually those are kids who have refractory seizures. And then you can see kind of everything else. So prognosis. So as I mentioned, most people will have resolution of their SWAS by puberty. the EEG may not be totally normal, and that's okay. In reality, we kind of are just hoping that the sleep-activated discharges get better. The concern, though, is the longer kids go untreated, the more we worry about their cognitive function. And so we know that children who had earlier onset ESES or ESWAS, and if they had a longer duration of EEG abnormality, they had a higher risk of more permanent or irreversible cognitive changes.
I know a cognitive rehab center in the East Coast, specifically for ESES, encephalopathy. Is there anything on the West Coast?
That's a good question. I don't know if there's a center that's specific to that on the West Coast. I know we don't have one specific to that in Seattle. I'm not sure about down south in California and Oregon. That's a great question. My gut answer, I would say no. We know that SUDEP, or sudden unexplained death in epilepsy, you have a higher risk the longer you go having uncontrolled epilepsy. And in a lot of these patients, they don't tend to have uncontrolled seizures. It's really the cognitive piece of the EEG change that's the problem. Yeah, but good question.
So if you had a child who's had ESES more than 5 years, dropping over 30 IQ points, when they go into remission, what's the highest improvement in IQ points or just improvements in cognition do you say in adulthood?
That's a really hard question to answer. I think we know that the longer you go without resolution of the ESES, the earlier you are when you have onset of this condition, the harder it is to make some of those recoveries. That's not to say that people can't make recoveries, and that's where we work really closely with our therapy colleagues and our neuropsychology colleagues, neurodevelopmental pediatricians. So I can't give you a number like, you would recover 15 IQ points, but I think there's not a good way for us to say exactly that answer.
Do you guys follow them into adulthood? Like what happens once when these kids become adults? What happens to them?
So at my center, and most pediatric centers, we follow patients till they're 21. There are some centers that follow patients throughout life. I would say that kind of the same answer I gave you before, that what happens when they're an adult kind of depends on what level of function they have and what they're able to do and what recovery they can make after their treatments have
They won't have another regression again. They won't come back.
We tend to think this is just a pediatric problem, and so not something that should recur. The risk of the seizures coming back kind of depends on why you had seizures or ESES in the first place, right? So if you have had a big stroke and the seizures really quieted down, but now someone's going through puberty and the seizures change, that's common. But so I think it's hard if you have if it happened for no good reason. We don't know. The MRI didn't tell us. The genetic testing didn't tell us. We tend to think that no, seizures should not start coming back all of a sudden, and there shouldn't be like a big regression again as patients get older. So just a couple of summary slides left, and then I wanted just to mention the kind of future thoughts. So I think this might help answer your question earlier about the spectrum of disease. And so there are a lot of acronyms and a lot of words on this picture, but I'll point you to the arrow in the middle. So all the way on my left, where it's more red, we think of that as the more severe EEG pattern, so just EEG pattern. And then all the way on my right, or the more orange part of the arrow, is the less severe EEG pattern. And so these were the more kind of benign focal epilepsies that we had talked about earlier in the orange. And then there's the group in the middle. And so those are the kids that, I think are the hardest ones because their EEG looks worse at night. They're maybe having some changes in cognition, but they haven't had a lot of regression. They haven't had a huge difference in their EEG pattern. And so they're kind of in the middle. And so I'd say this is kind of where our spectrum is right now. Another just summary slide kind of highlighting the column all the way on the right. We're under mandatory is what you kind of have to have EESWAS. We've talked about this a lot. Activation of the sleep EEG, regression of development and cognition, and then long-term outcome at the bottom here is that you should have remission by mid-adolescence. You may not have a totally normal EEG, but that's okay. That depends on why you had epilepsy in the first place. In the middle column, there are some alerts, so maybe consider a different diagnosis if you have these issues, such as tonic seizures, or your seizures started really early in life, or you have more of that Lennox-Gastaut picture on your EEG. And then we have the exclusionary criteria all the way on my left, which is with epileptic spasms or with the age under 1 or over 12. Okay, in the last few minutes, I know we're almost done, but future directions. There are a couple of clinical trials going on right now. Rescue ESES is in Europe. It's a study looking at the use of corticosteroids versus clobazam. It's an ongoing trial. We don't have results yet, but I think that'll be a really interesting discussion to see is one better than the other. Out of New York, there's a study looking at the use of cannabidiol, which is the non-psychogenic form of marijuana, and looking at the use of CBD or Epidiolex versus placebo. And so that's what we call a double-blind randomized placebo-controlled trial. So we look forward to seeing the results of that. A lot of people talk about precision medicine, and so if you have a genetic condition, is there a specific genetic treatment or targeted therapy for your condition? Most genetic conditions do not have a very specific treatment right now. We do know that there are some things you stay away from in certain genetic conditions. And then the last piece I think is one that's really exciting. Haven't seen any clinical trials for this yet. There are a couple of case series looking at VNS or vagus nerve stimulator, one of our oldest neuromodulation therapies. But also you could think about is something intracranially like the deep brain stimulator or responsive neurostimulator, is that an area that we could think about to help treat this condition? So with that, I know we have like 2 minutes. I'd like to take any questions, and thank you so much for your attention.
CSCS was brought up before and wanted to know if it was possible treatment for ESES or possible, like what they're thinking about. Have you heard much about the CSCS, the neuromodulation CSCS trial coming up in 2020?
The transcranial magnetic stimulation, or?
No, CS cortical, what was it? CSCS, Dr. Heislop mentioned it.
Oh, okay. Yeah, I don't know anything specifically about that.
Okay. I just wrote it down as CSCS, so I don't know.
Yeah, right now the neuromodulation therapies we have are vagus nerve stimulation, deep brain, which goes into the thalamus, responsive neurostimulation, which can go in the thalamus or the cortex, and then transcranial magnetic stimulation, which is kind of a cool device, something that we're thinking a lot about in this condition and other epilepsies, that is kind of more like an outpatient treatment where you provide the stimulation to try and interrupt the seizure patterns.
This one, the CSCS, they said it's trialing right now.
Yeah.
But it's specifically more for children.
Okay.
So, and
Great.
they're saying like it might be promising for the ESES people.
Okay. Yeah.
Or anything more, but I guess it's really, really, really new.
Maybe we can take one last question if you guys have one. Otherwise, I'll let you enjoy the rest of your day. Thank you so much.